Welcome everyone to our virtual 2021 PWS Family Conference presented by Soleno Therapeutics. Before we begin today's presentation, let's first thank our amazing sponsors, Soleno Therapeutics, Levo Therapeutics, Harmony Biosciences, Radius Health, Inversago Pharma, Saniona, Consonance Therapeutics, and Novo Nordisk. Their support allowed us to make this conference free for all of our community members, and we are incredibly grateful for their contributions. Today, we will be hearing from Dr. Jessica Duis. She is a board-certified pediatrician and medical geneticist who practices in the area of genetics and complex special care pediatrics. She has focused her career on chromosome 15 disorders, including duplication 15q, and her career has spanned translational, clinical, and bench research. She's passionate about establishing standards of care and personalized therapeutic interventions for individuals with neurodevelopmental disorders. She's designed and worked on many clinical trials and currently focuses on management guidelines and establishing outcome measures that quantitatively capture clinically significant features of nerve development disorders in the natural environment. And that is a tongue twister. But without further ado, I would love to pass it off to Jessica.
Thank you so much, Sarah. I'm really excited to be here. Let me go ahead and share my screen. Okay, well, welcome. So without further ado, I'll go ahead and get started so we have plenty of time, hopefully, for questions. So my goal today is really to discuss what evidence-based care recommendations are out there for this age group from 0 to 2. We'll then kind of transition over to experiential data without clear evidence in the medical literature for use in PWS. We'll talk about some features of PWS at this age and treatments, and we'll hopefully provide some resources and tools to you to empower you to educate your child's providers, and actually I'd add to that your child's school and caretakers as well. So oftentimes, as many of you probably know, Prader-Willi syndrome starts off with symptoms of low muscle tone and feeding difficulties in the infant period that often end up where the child is in the neonatal intensive care unit. Oftentimes, augmentative ways of feeding the individual are needed, even if just for a short period of time, such as an NG tube, as is pictured here. So step one is to establish the diagnosis of PWS. And I'm sure this is review for many of you, but I do always like to go over this in this particular age range, just to make sure that individuals understand chromosome 15, which is very complicated. So this is a picture of chromosome 15, and chromosome 15 is very unique because certain genes are only turned on from dad's copy, and certain genes are only turned on from mom's copy. And then other genes, which are called non-imprinted, are actually turned on from both mom and dad's copy. And so these genes in green would be biallelically expressed or expressed from both mom and dad's copy. The blue genes in the Prader-Willi syndrome critical region are only turned on from dad's copy. These orange genes are only turned on from mom's copy of chromosome 15. And then we have some additional genes towards the end right here that are expressed from both mom and dad's copy, including some genes that are very important for the inhibitory hormone in the brain called GABA. So most individuals have a type 1 deletion, in which they have a deletion from breakpoint 1 all the way down to breakpoint 3. There are some individuals who have a slightly smaller missing part of the paternal copy of chromosome 15 who have a type 2 deletion, and that would go from breakpoint 2 to breakpoint 3. So when we're trying to establish the diagnosis, we see an infant in the NICU often with low muscle tone, poor interest in feeding. The best test to get is something called a methylation test. And DNA methylation test looks specifically at what genes are turned on in that maternal versus paternal copy. And in 99% of cases of PWS, you would find that that methylation test is positive and confirms the diagnosis. Taking it one step further, to confirm the particular mechanism by which we have absent expression from the paternal copy, we can do several different tests. We often start these days with a chromosomal microarray, which is a test looking for small missing or extra parts or pieces of chromosomes, including chromosome 15, but across the entirety of our chromosomes, so all 23 pairs of chromosomes. You can also pick up uniparental disomy, in which you inherit 2 copies of mom's chromosome 15 and therefore have absent expression from dad's copy with this test, because it looks at something called single nucleotide polymorphisms, which is a big word to just say common misspellings or changes in letters of the genes themselves that can help us identify if the individual has received 2 copies of chromosome 15 from mom. Sometimes, depending on the type of uniparental disomy, you may need some additional uniparental disomy studies, depending on when this occurred, or you may need to do additional testing to look at the imprinting center, which controls how genes are turned off and on chromosome 15. So how many of you felt this way when you heard the words PWS and your child got a diagnosis? And I would say the first step when you get this information is to give yourself time. You really need to support yourself and your family as a unit. Really avoiding reading on Google is always a good idea, especially since you're going to find misinformation. You're going to find the most severe cases. The first cases that were ever picked up with PWS are going to be the most severe. And you want to wait to gather information until you're really ready, to dig in. And that's different for different individuals. Facebook can be a fantastic resource, but you have to be careful. A lot of times we have families feel more overwhelmed and upset by entering some of the Facebook pages. So again, it may be waiting till you're ready, or it may not be the best source of information for you. And there's really no single right answer. And you're going to have good days and bad days. And it's very important to just keep reminding yourself what a warrior and fighter your kids are. They are determined to succeed. They push themselves to the limit, and they want you to be proud of them. They will really teach you to find strength. And your child will want to do what other kids do. And your job is to support them and love them and push them. And even if they're not the best on the team, they still want to participate in organized activities, and they have their own ways of being competitive that doesn't have to be being competitive with other children. And then I can't emphasize enough, again, there's going to be some good times, there's going to be some hard times, and never lose hope. There's so many reasons, as we saw in the videos, to be excited about the future for all individuals with PWS. So, and remember, you got this. So let's kind of go through a little whirlwind here of important concepts of taking care of kids in this age range. So we'll talk about skin to skin and just enjoying your baby. Kids with PWS love to snuggle. So it's something that you can definitely take advantage of and enjoy because they grow up very fast. Physical exam, we'll talk about some things that you need to be looking for and thinking about. Feeding and nutrition, and remembering a fed baby is the best baby, no matter how you feed them. We'll talk a little bit about supplements. We'll talk about therapies. And of course, the only FDA approved treatment right now, I think this is going to change, but right now is growth hormone. And then we'll talk about oxytocin just because it's a common conversation and question that families ask in clinic. We'll talk a little bit about self-care. So it may seem like your baby is sleepy, not that interactive, but your baby knows you're there. And it's so important to enjoy those bonding moments, skin to skin. It helps with many things, which there's a lot of evidence of in the medical literature. It really helps strengthen the family unit. And again, they grow up so fast, so just enjoy those snuggly moments. And it will make you feel less helpless, is what the literature shows. So jumping right into some of those physical exam findings. So in boys, undescended testes are very common. About 70% of males with PWS have at least one undescended testicle. And so we get a lot of questions about HCG. And unfortunately, it's never covered by insurance. There is minimal data about this and differing opinions, so it's definitely worth talking to your endocrinologist and urologist about. But there is some medical literature to support potentially bringing the testes, or it helps with the actual surgical procedure of bringing the testes down, because it does help with enlargement of the scrotum to make that more stable for that procedure. So even though many individuals still go on to need the procedure, which is called orchiopexy, it may be helpful to treat first to help with that stability. And so if you're thinking about that, I put the dosage in there that we often use or what's reported in the medical literature. Developmental dysplasia of the hip is very common, and I would say there's some differing viewpoints about this. Definitely, we recommend strongly, especially if your child is breech, but all kids with PWS, that at 6 weeks of age, they go ahead and get a hip ultrasound to look at this specifically. And there's been some medical literature out there, not many published papers, but one in particular by Trisno et al. That does talk about subsequent radiologic imaging looking for developmental dysplasia of the hip. And it's pretty aggressive screening. So it recommends pelvic x-ray in the frog-leg position at age 1, 2, 5, 10, and 15 years of age. Treatment is also controversial. If it's picked up early, a Pavlik harness can be used or other types of bracing, and then potentially surgery would be needed. We get a lot of questions from families about shallow acetabulum, and this is relatively common. And I would say, talking to many orthopedic surgeons, you get many different recommendations. I would say the main thing is to continue to follow these findings over time with an orthopedic surgeon. So when we're talking about this age range of 0 to 2, we're talking more about the early stages, low muscle tone, decreased interest in feeding, and we may get over to phase 2A where there could be a weight increase without an increase in appetite. So here's our first poll question. So we'll go ahead and put that up for you. What are some ways to facilitate healthy feeding in an infant with PWS? And I'll give you about 30 seconds and then we'll look at your answers here. Okay, let's see what the responses show. Perfect. So most people said all of the above, and that's absolutely true. You want to try many different options when you're trying to healthily feed your baby with PWS. So let's talk a little bit about that. Let's see if I can. Okay, perfect. So a fed baby is a healthy baby, and this can be the most stressful part of PWS is the early feeding concerns, and it is present in, not sure what, sorry. It is present in 99% of infants. So some feeding difficulties are pretty much present across the board. So remember, every other parent is pretty much going through the same thing. And this is where gathering that team and support group can be really helpful. So you want to do everything you can to make your baby uncomfortable to get him or her awake. So unclothing her, providing some stimuli, trying different positions can be really key. And we'll talk a little bit about one position that I have found to be very helpful working with a lot of different feeding therapists. You want to try different bottles, and we'll talk through some of those. And then support your child as they need to be supported. You want to make sure that they're getting the nutrition they need to grow. And so we are working on more data in this area about specifically what complications go along with feeding tubes, and we're working very closely with FPWR to do that through the global registry. And so we're trying to understand more about this, but we want, our suspicion is that the healthiest thing to do is an NG tube and send families home with training, potentially because of the complications that may be more common in individuals with PWS who get gastrostomy tubes. That is not the answer for everybody. It's a very individualized decision, but we're trying to get some more information to give you more guidance there. So I'm going to talk a little bit about positioning, and I'm going to try to play this video. Let's see. I'm going to turn off. So this is a video about the side lying position, because I have found it to be the most successful if you want to try to breastfeed, but also for the safest bottle feeding. And so I think it's worth taking a minute just to talk about this position. And this is an infant taking a bottle, but you can see that it does seem to help prevent those aspiration events. Supporting the head at the neck is very important. Holding the bottle at that angle is very important too. So that is the side lying position. And there's many other positions. It's worth working with a feeding therapist to really find what works best for your child. But this is one that we have found to be very helpful. And then you want to pace. So giving a break, and then taking a little break and then giving another try. So aspiration is very common in PWS, and this is probably one of the most common phone calls that I get from providers across the country, which is that they see a child with PWS, they're concerned about aspiration, and what is our threshold to go ahead and get a swallow study? And of course, we definitely want to know about swallowing dysfunction, as it can be dangerous. Individuals with PWS do tend to aspirate, and this is not unique to the infant period. This is common, what seems like throughout life, in some of the studies that Roxanne Gross has done. And this study specifically was done by Parisa Salehi in Seattle, and it is very common for kids to have silent aspiration, meaning that there's no signs when you're feeding the infant that they're aspirating, they're not coughing, they're not sputtering, but they do have some swallow dysfunction causing residue, so leftovers in the mouth that then can result in aspiration events, and a good percentage of them. And the question is, what do we do about this? Working on positioning and safety, monitoring for symptoms. So if your child does have lots of pneumonias, that can be a sign that they're aspirating, and maybe that we need to find a safer way to feed them. But in general, it's really just clinically monitoring that we're doing. This is not prompting in everyone a change to a different way to feed them if they're keeping up with what they need to take orally. Nipple flow rate has been shown in the medical literature to be helpful. So sometimes these data actually can result in thickening of feeds or trying a different nipple that works better for your child. And for kids with PWS, the slower the flow, the better they seem to do. So there's lots of bottles out there. There's many options, and these are the ones that we really have found can be great for individuals with PWS. I would say the most common one is the Dr. Brown's feeding system, which has a little valve that helps with self-regulation of feeding for individuals with PWS or anyone. And so this is probably the bottle that we're using the most and having the most success with, but there's other options. Something to control flow is very important. NG tube feeding is something that lots of kids go home with. And so we do recommend, if parents feel comfortable, that NICUs be comfortable training them to use an NG tube. There's, again, very little data about outcomes of NG tube versus G tube. We have always talked about this theoretical risk of stomach rupture at the site of a scar when someone has a G tube, and we're trying to more systematically collect some data about that. And those stomach ruptures would be theoretical risks later in life. And then we should hopefully have some more data about this for you soon. So another poll, when monitoring your infant's weight gain, what is the most important factor? Okay, we'll put up the answers. Okay, so this is, I think I'm looking at my answers and I think it was a hard question to answer because B and D are a lot alike, but the answer was actually B. So we don't need to focus on what the growth curve suggests is important for the specific age of the individual. We need to monitor the curve for your child. And so it's very important that we look at the day-to-day growth, even if they're way below what we would expect for the curve, it's more that pattern of growth in your individual child. So we do follow the growth curve closely, but we don't think that there's any specific point on the curve that that child should absolutely be at for weight for length. Your child will follow their own curve, and that's okay. We want to make sure that they're gaining weight appropriately for the pattern they're following. And there are some recommendations for day-to-day weight gain that can be helpful, but again, it doesn't have to be on the growth curve. Reflux is very common, and this can also be a risk for aspiration. We think as many as 90% of individuals with PWS have reflux, and reflex precautions are the most important intervention. So making sure that you feed your child in as much of an upright position or side position that you can, and then keeping them upright for a good 30 minutes after they eat, even if they're doing tube feeds, is a good recommendation. And then we often have to maximize treatment with standard therapies for reflux. Nissen funduplication is actually a procedure where they wrap the stomach around at the esophageal stomach junction to prevent things from coming back up from the stomach into the esophagus. We generally do not recommend this procedure for individuals with PWS because eventually they're going to eat on their own. And so it can be a risk for difficulty swallowing or food aversions, and it can also make gastric emptying take longer, which can be a lifelong problem for PWS. That doesn't mean if your child has it that you need to be worried. You can still feed them by mouth, but we need to be watching out for that stomach emptying in particular being a little bit slower. Introduction of solids can be done when your child has good head control or is able to have good head control in a very supportive chair. Usually we wait 3 days to a week before we introduce new foods just because of common allergies to foods in this population. And we still want you to avoid added sugars. So looking at labels or making your own foods is a good idea, and always avoid juice. Liquids and cups. So cups are learning to drink from a straw is very important because it also can help with oral muscle tone, which can be a problem in PWS. So you want to try to pick the right cup. This is the Honey Bear cup, and it's often a good place to start because it can help kids learn how to use a straw. But using these weighted straws can be very helpful. Oftentimes kids with PWS, any kids, when they're learning to use a cup, will tip it upwards, and that will help them to still be able to use a straw. Introducing fluids, in particular water, very early is very important. You don't want to use any fluids with a lot of added sugar, and really avoiding juice is very important. So you can start solids once your child has mastered purees or is getting good with them. Again, you really want to think about the long-term goals of diet, even in this early stage. So we really recommend focusing on nutritious carbohydrates or low glycemic index carbohydrates, meaning that they don't lift the blood sugar very quickly, but keep a steady blood sugar even when you take them in. So non-starchy vegetables, such as what I've described here. Fruits, you want to focus on fruits that have a low glycemic index as well with high fiber content. Avocado is great because it has lots of healthy fat in it. Grains, again, you want to focus on high fiber content, and you want to avoid those simple carbohydrates like white breads. Proteins are very important, so lean meats in particular, good fats. And you want to, even from the beginning, just think about serving sizes of what's appropriate. But at this age, again, we really want kids to be just gaining weight appropriately for them. So I'm going to talk a little bit about supplements. I'm going to breeze through this a little bit just because there's so many out there. I'll focus on a few. The key to supplements is that you just don't want to introduce too many things at one time, one thing at a time. Try it for 2 weeks. Really stop it if you don't think that you're seeing any benefit, and then try the next one. And, I want to emphasize that there's just not a lot of data out there, and it's hard to do randomized clinical trials in this area because they're expensive and these are widely available supplements. So many things are out there, and we'll jump into a couple of these. Coenzyme Q10 is one that's commonly used in this infant period. And, it, again, there's not a lot of clear evidence for use, but it may support the powerhouse of the cell called the mitochondria, which is responsible for energy. Think of it as the factory of the cell. And it may also improve duration of sucking in infants, as well as daytime energy level. There are some studies that showed that potentially this is as good as growth hormone. That does not mean that they should be on it instead of growth hormone. Everybody should be on growth hormone, but maybe it has some additional helpful impacts. And so there's different dosing recommendations. A lot of people just use a standard dose of 100 to 200 milligrams a day. There's no randomized controlled trial, though, in individuals with PWS. And you want to be careful about sugar content when you're looking at coenzyme Q10 preparations, a lot of which are liquids. And so actually the best one is one that you can get at Costco that doesn't have any added sugar to it, called Qnol. Levocarnitine is another one we see frequently in this age range. There's no significant differences reported in the literature with the use of this, but there has been some reports of decreased carnitine levels seen in individuals with PWS. And then I have to say, there was an article that came out in 2017 that suggests maybe an association with deficiency in carnitine linked to non-syndromic autism. So it's something, again, that maybe helps with stamina and energy and alertness, and something that is often tried in this age range. MCT oil really is interesting because it does really help the types of diets that we think are most beneficial for PWS, in particular those healthier carbohydrates, nutritious carbohydrates, and lower carbohydrate diets focusing on protein and fats. And there is actually some evidence that MCT pushes ghrelin, which is the hormone that tells us we're full, to its active form, which may be impaired in PWS. And so it's something that we think could add some additional evidence that maybe it's helpful. You have to be very careful about it because it does have calories, but we start one to 2 teaspoons usually a day to start, and then you can do up to 3 teaspoons with meals during the day as individuals get older. The main side effect of this would be a little bit of diarrhea, so it may be helpful actually if your child has some constipation. B vitamins are very challenging because individuals with PWS seem to have very high levels, particularly of vitamin B12, and we're really not sure if that is an indication that individuals with PWS just don't use B12 efficiently. B12 symptoms, if you're low or you don't have functioning use of B12, could be some things that we see in PWS, such as cognitive difficulties, fatigue, and problems with balance. But there's no evidence to suggest that individuals with PWS should be on B12 and what formulation is best. DHA, often in fish oil, can be low and have an impact in neurodevelopmentally. This hasn't been shown in PWS, but has been shown in other disorders like autism. And so this may be something to try as well. And there's not any specific data in PWS, but like I said, it has been shown to perhaps be effective in underperforming children or those with neurodevelopmental disabilities. And a multivitamin is often helpful, particularly if you're thinking about some of these restricted diets. Any infant who's getting breast milk should be on vitamin D. And then there are some different formulations that seem to be a little bit better if your child needs iron. One of those is NovaFarum pediatric drops. And one vitamin I use a lot is NanoVM. One, because it's very supportive of not increasing sugar, doesn't have any added sugars, very actually what we call ketogenic friendly, which is the most restrictive of these types of diets. And it also doesn't taste good and comes in a powder, which can be helpful. Pre and probiotics, there's a lot of interest and data about out there, not necessarily specific to PWS, although there have been some recent studies. I know last year presented at FPWR, and then maybe some recent medical literature suggesting the role of probiotics in PWS could be helpful. In general, the gut microbiome plays a very important role in the development and function of the central nervous system, including metabolic factors and neuroendocrine regulation, which might be very important for PWS. So it's not really clear what preparations are best for PWS. There are some combination probiotic and prebiotics available that I know a lot of families use. And this certainly could be very important for gut health, in which there are some concerns, in particular constipation in PWS. There is a little bit of literature on B. fragilis that it may be a helpful additive to probiotics that could be helpful in PWS, but more work needs to be done here. And I can't emphasize enough the role of therapies and early intervention. So immediately when your child gets a diagnosis or when you're in the NICU, starting the process for early interventional services is very important. Asking for feeding consultation right from the beginning, because kids with PWS should be allowed to feed, and working with them on feeding can be so important. You know, a lot of states only offer and start with developmental therapy, which means a lot of times you're needing to do some private therapies. Adding PT early by at least 3 months is very helpful. You know, there's a lot of people out there who talk about, you know, working and pushing your child ahead of milestones, and that this could be associated with scoliosis. We just don't have the studies and the medical literature to support that. But certainly a supportive chair, as I showed with feeding, can be extremely helpful in preventing scoliosis, we think. OT for fine motor skills and sensory processing skills, and then speech is really important, because a lot of kids with Prader-Willi syndrome have a problem with the motor production of speech. So cognitively, it's there, but the issue is really getting what's in the brain out through the mouth from a motor planning perspective. And there are certain types of therapy that can be really helpful for that type of problem, including prompt therapy. There are some people who have done neuromuscular electrical stimulation of the pharynx for this indication, and also for feeding. And again, there's just not much evidence there. We get a lot of questions about behavior, and I would just say at this age, the behaviors that you see are pretty typical for age. You always want to teach your child the same values and lesson you envision for all of your kids. You want to have the same expectations you would for your other kids. And you can see some rigidity and stubbornness that arises even this young. And so implementation of really positive environments in which you're really praising and providing rewards for positive behavior is so important, because that's a lifelong skill actually for all of us. You know, activities for toddlers and getting out there and being active is a good thing. Of course, we have to be careful, and a lot of things are closed because of still of the pandemic, but you want to get out there and give your child opportunities for social interaction. And don't feel bad putting your child in daycare. You want to find a good environment where you feel comfortable so you're not worrying all day, but it's really good for kids to get that social interaction if you need to put them in daycare. And then growth hormone, I could spend a whole hour session just talking about why growth hormone is so important. It's the only FDA approved therapy for individuals with PWS. They should get it in the NICU. It is, I know that there's not that much evidence to suggest that. And we are definitely something our community needs to work on. But getting it started early, I think, really does help with muscle tone and feeding. There's no contraindication to getting it started in the NICU. And so we have really been pushing at our institution for that to happen. I would say there's so many benefits here. Maintenance of lean muscle mass compared to fat mass, maybe some cognitive impact. You know, the data is varied in terms of sleep disordered breathing and association with growth hormone, but for the most part, most of the studies coming out show that it is safe. You do want to work with a sleep specialist and someone who is thinking about enlargement of the tonsils. This tends to be the worst right after starting growth hormone within weeks, and then by 2 years, that risk seems to go down. Sleep disturbances are just common in general, and we have to get sleep studies to monitor kids with PWS. The recommendation from the FDA is that you get one after starting growth hormone, and generally before starting growth hormone, although a lot of times we're foregoing that first one, especially if they're in the NICU and they've had monitoring. But getting that second sleep study, which we're typically doing around 4 to 5 months. Obstructive sleep apnea is common even in the infant period, and there is some data to suggest we should be doing drug-induced sleep endoscopies, which is putting your child to sleep and seeing what their airway looks like while they're sleeping. You know, this is just my opinion, but I think the medical literature is supporting that. I don't think kids should be stopped from using growth hormone if sleep apnea is noted. Now, it is a patient by patient decision that we make, but it is very important that they get the growth hormone because that does help with muscle tone, which in the long term can make the sleep apnea better. Central sleep apnea is common, particularly in infants. And basically what happens is when you have an increase in your carbon dioxide and a decrease in your oxygen, your sleep center in your brain should take over and tell you to breathe. And in PWS, that can be impaired and that can cause central sleep apnea. And so the most effective treatment in this age range would be use of oxygen. Another poll here, how might narcolepsy and cataplexy commonly present in this age range? I'll give you about 30 seconds and then we'll put up some answers here. Okay, we'll look at the responses. Okay, perfect. So a lot of these are all of the above. And one thing I want to point out is that one of the early signs we think we're seeing of this narcolepsy, cataplexy clinical picture that we're seeing in PWS is when kids are eating and they kind of enjoying their food kind of start to fall asleep and you see their eyes close and their head kind of drop. So narcolepsy and cataplexy are probably just part of PWS in some form. They don't typically meet the clear criteria for the diagnosis. They don't have the same changes in or a hormone called orexin, which we can look at in the cerebrospinal fluid, but they do have a lot of the features as they get older and even in this young age range of narcolepsy that I've listed here. And so it is really important to pay attention to and be thinking about for your child with PWS. Other treatment considerations, so scoliosis is common, and a lot of times we just need to get x-rays to monitor for scoliosis, and the recommendation is at least yearly because kids with PWS can get what's called an S-shaped curve. So they can have a curve at the top and the curve at the bottom, and then when we're looking at the spine, it can look completely straight. Definitely constipation is common, and I definitely recommend trying some natural supplements, and I'd add to that list pro and prebiotics. Allergies are perhaps under-recognized in this population, but very common. Persistent reflux, vomiting can be associated with eosinophilic esophagitis. And so that's something to just make sure that you're aware of and that you bring up with your physicians. And then kids with PWS have this very thick saliva, and the recommendations in the AAP guidelines, so the American Academy of Pediatrics, is actually that they have dental visits every 3 months, starting at age 1. So there's a lot of interest in oxytocin. We get this question frequently when we're talking to families, and I would say there's some evidence, in particular started with data from 1995 showing that the oxytocin expressing neurons in the hypothalamus was decreased in PWS. So maybe we are making less oxytocin if we have PWS. And there's some varying data. The data from France supported that maybe it was helping with the oral suckling of infants with PWS and maybe improved that risk for aspiration. I would say this is all very varied data. And of course, on the horizon is, let's just say, carbetocin, which has been potentially shown in the study that was published to have some impact on anxiety and potentially hyperphagia. So more to come in this area. One thing I will say about oxytocin is that it appears safe. So in early studies where they were using doses like 40 international units per day, it did seem to cause some aggressive behavior potentially. And that was in older kids, in adolescents. In the doses that we try it, if families want to, after a long discussion of the risks and the unknown benefits, but potential benefits, we sometimes do offer it to families. It's not covered by insurance, and it may have some positive impact. And I have families using it in many different ways. And it's certainly worth talking about and just understanding the potential benefits and the risks of using it. So we are working really hard to create resources. This article's getting old here, but we have tried to put out as many as possible evidence-based approaches to taking care of individuals with PWS. And we want to put these out so that you can have care close to home and that your providers can understand all these nuances and important considerations for PWS. And I just can't emphasize enough how exciting the future is for PWS. You'll see this afternoon some presentation of data that I think is very exciting on DCCR from Soleno. There's already some data in pitolisant, which is in clinical trial, from case studies that look like it could have some very good benefits for PWS. And there are more than 10 drugs in phase 1 to 3 clinical trials for PWS. And then I think there's like 9 other companies, if not more, that have drugs in preclinical development. So this is just huge. So the future of PWS looks bright. It's different from how we know PWS right now. And I'm happy to take any questions.
Okay, we have a few questions. Sorry, I'm working with the controls here. We have a few questions. We'll start with the first one. The dose, this is from Rebecca Noel. She said, the dose we're doing for our baby of carnitine is different than the dose recommended on your slide. We're also only adding it once a day instead of twice. What is the reason it is recommended to split the dose into 2 times daily?
Good question. So, and of course, we don't have established dosing, so everybody may use it differently. I tend to use 50 milligrams per kilogram divided in. So, and that is the full day dose divided in 2 doses. The reason that we do it in 2 doses is that it can be very GI irritating and make reflux worse. So, we find that spreading it out gives a little more opportunity to prevent side effects.
Great. Another question is from Marianne. If my daughter eats 2 to 4 portions of fish per week, do I still need to supplement with omega-3?
Probably not. I don't think getting extra has been shown to be hurtful, but no, probably not. If you're giving that much fish, which is absolutely wonderful, you probably don't need to also supplement.
Great. Another question from an anonymous attendee is they are having a difficult time getting their child to drink water. They completely resist it. Do you have any advice to help with that?
This is really common. Individuals with PWS do not like water. One thing I would say that I have seen be very successful is to continue to only offer water. And the other things that we find helpful are to use natural ways of flavoring the water. So a lot of times we recommend actually buying frozen fruits and vegetables, which make the water very cold. So frozen strawberries, frozen mango, and you only need to put a couple of pieces in to get that cold water. Even put it in there and then put it in the refrigerator overnight. Some kids, if they see the color change, so if you put some strawberries in and you leave it overnight, it makes the water a little bit pink. And sometimes seeing that makes them think that they have a flavored juice, which can be really helpful. Um, the other strategy that works really well is using it before meals. It's a whole family implementation of saying, you must drink your cup of water before I serve your meal, because most kids don't drink enough water. And so pushing that in that way can be really helpful. The other thing I have done in clinic, which has been a lot of fun, because it makes kids super excited to come into the clinic, is work with the kids myself to say, okay, keep a log of how much water you're drinking. And if mom agrees and you are really drinking a lot of water, we give them a little prize when they come in. And that has kids with PWS can be so competitive in that way and really want to meet those goals and please you. And so that's worked really well as well.
Yeah, my daughter's 12 and she's highly motivated by positive reinforcement. So that works for us as well. And honestly, the more that she drinks water, the less we have to reward her. And over time, she's developed an actual taste for it. So it works over the long run. Another question, how frequently, this is from Jessica Ross, how frequently should sleep studies be done on an ongoing basis?
So I think this is changing, and we have a little sleep guideline recommendation paper that should be coming out soon. But in general, the recommendation has been around the time of growth hormone, as I mentioned, and then as symptomatically needed. For example, if there's a change in school performance or change in behavior, it could be new onset of sleep disturbances, such as sleep apnea. Our clinic has been talking a lot about this, and I think we're leaning more towards at age 3, potentially repeating a sleep study, making sure we're not missing something, and then really going from there and looking at how things look symptomatically. And we're finding that every couple of years it makes sense to get one. So a changing recommendation at this time, definitely pay attention to symptoms. And then I would say as kids are getting older, particularly if their weight is changing or if you have concerns, having a low threshold to get one is important.
Okay, the next question is from Angie Wang. She asked, she said, my daughter is 11 months old. She started solids a few months ago. How strictly should we control what she eats at the moment? And when should we stop with formula that we give her alongside solids?
So, so that's a hard question to answer because it's helpful to know how much she's eating. I would say you want to follow general meal plan, like so you would do 3 meals a day if you're doing smaller meals, 2 snacks and 3 meals a day. And the more important thing I think is focusing on even at this age, I would say focusing on the foods you're giving her. So no added sugars, making sure they're healthy and nutritious carbohydrates if they're carbohydrates, or focusing more on protein and good fats and a few grains and vegetables is probably a good way to go. In terms of formula, generally we change over formula at age 1. Everybody is different, so it is sometimes helpful to have more information, but generally we change over to milk at age 1, and we like to use ultra filtered milks that have more protein and less carbohydrates, and you can get whole milks. So Fairlife is one. And so they need between 16 to 24 ounces a day around age 1, but you don't necessarily want to be giving it in a bottle. You put it in a regular cup, working on using the straw again and using more regular sippy cups for giving milk.
Thanks. Tracy asked, our ENT is recommending ear tubes as a preventative precaution to assist in the flow of her secretions and drainage. Any thoughts on that?
So it's helpful to know if there have been ear infections or if there's concerns about a lot of fluid in the ears that could be impacting hearing. The data suggests that that doesn't affect hearing, but a lot of anecdotal evidence would suggest that if there's a lot of fluid in there, it could be impacting how words are heard. Kind of think about hearing things when you're underwater. In and of itself, just as a preventive measure, not usually. Only if there's some indication to do so would we typically recommend that.
Okay. Another person asked, how much PT would you recommend for our little ones? My son is 13 months and starting to crawl and pull himself up. He is only getting 2 sessions of PT a month. I think it's not enough.
Yeah, that's probably not enough because you want to do everything you can to support appropriate development. Generally, I say 1 to 2 sessions a week for that age range. So definitely work with your providers and see if it's possible to increase that.
Another thing, if you're having a hard time getting it increased, finding programs that help develop strength, like swimming, swim classes for babies, things that you could do. But yeah, ideally you would get into therapy, but I know sometimes resources are limited. So finding other fun ways to work therapy in is also an
Absolutely.
option. Here is another one. It says, my 9-month-old son is not currently on any supplements. Which supplements would be most beneficial to try for his age? He is not overly sleepy and is eating well by the bottle and purees.
So I don't know that you need to start any supplements. If he is getting a well-balanced diet, it is sometimes helpful to check some nutritional labs, check an iron, check a vitamin D, even check carnitine level, and see if he would directly benefit from supplements. The other thing that can be helpful is maybe a pre and a probiotic can be helpful too. But I don't think that there's any specific supplements that we would say anybody has to be on, and probably a routine nutritional evaluation is just indicated.
Great. The next person said, my daughter is 6 months and has really found her voice. Should we start speech therapy now?
Yes, definitely. I think one of the things we see often is that a lot of families get told hold off on speech therapy. They don't need speech therapy yet. And I would say the best sign that they to start something like speech therapy is how vocal they are and what sounds they're making. So I would recommend doing that.
Great. Rebecca Noel said, how can we get this information out to all hospital NICUs so that it is more likely to happen right as the diagnosis arrives? Our NICU didn't want to start our son on growth hormone until 6 months of age.
The thing that's the most important in terms of that is more data and having some data in the medical literature to support using growth hormone. And if not just support using growth hormone from showing positive benefits, at least show it's safe at that age, and that there's no side effects. So I think the best answer to that is that we need to do a better job of putting that out in the medical literature. Certainly, you're welcome to share slides, or I think this is actually going to be available via video for anybody to watch. So sharing that with your providers. And then you can always have your providers reach out to us. I'm happy to talk to anybody and advocate for those particular interventions sooner.
Yeah, I know we've looked into this, especially with the First Steps New Parent booklet that we put out on FPWR, just trying to get that information out to people as soon as possible. It's difficult. NICUs, there's a lot of NICUs, and to get it into the hands of the right person and to know that they will actually follow through. But I do think that if there's someone local who could follow up, that's always extremely helpful to get the widest spread of just making sure it's followed up with, and that they know who to turn to if they say, you know, oh, hey, we have a new parent and I know you're familiar with this. A lot of times NICU support will reach out to other parents to see if they connect you. So if you reach out to them, that might be the best first step. Another question, and we have 2 questions left and then we'll have to wrap it up due to time. One question said, because of COVID, we can only do OT and PT virtually. Do you have any recommendations how to better approach this situation and advocate our need for in-person visits?
This is something that we're battling everywhere, I would say. And, you know, certainly we're happy to help advocate for the importance of in-person visits. Asking your OT and PT to give you detailed directions of what you can do with your child can be really helpful. We are finding that kids have trouble getting a lot out of virtual visits, and it's falling a lot on the parents to really be there and work with the child. Trying some of those other things that Sarah mentioned, like getting into some, aqua therapy or other opportunities, hippotherapy, potentially depending on your child's age, can also be helpful. And it's just a really tough problem right now, and a lot of places are still doing mostly virtual. But providing that education and making it clear how challenging it is to do that yourself is very important, and having your pediatrician and your providers support you on that.
Mm-hmm. You might have to look into a new provider. I know different clinics around town here where I live have different COVID protocols. And so if one was only doing telehealth, I think I would look into what other providers my insurance covers and call around and see what their protocols are. Because I do think, especially with PT and OT, that hands-on experience is so important.
Absolutely.
Okay, the last question. How do families find a pediatrician expert in PWS?
I think the more important thing is finding a pediatrician who's willing to learn. It is hard to find a pediatrician who's taking care of a lot of individuals with PWS. Really, I think if you have a local PWS clinic, working with them to see if there's someone they could recommend can be helpful. But the most important thing is to find a pediatrician who's an advocate. You're the expert on PWS even more than any providers, and making sure you work with someone who hears you, who's willing to potentially work with other providers who are experts on PWS to learn and make appropriate recommendations can be really helpful. And then directing them towards some of the resources that we've talked about can be really helpful too.
Yeah, definitely finding a pediatrician who's open-minded and willing to listen is always a helpful place to start. We're willing to reach out. I know when we we talked with our pediatrician when our daughter was first born, and she said, yeah, connect me with anyone who knows more than I do. I would gladly talk with them. And I think I would assume that Dr. Duis, you hear from other pediatricians and doctors who reach out to you specifically to ask you for information as well.
All the time.
Yeah. Well, with that, we are concluding our Q&A. I have to say thank you, Dr. Duis, so much for taking the time to just spend with us on this day. And just your willingness to always be an advocate for our community. I know that with COVID, a lot of people are missing that face-to-face time, and maybe you don't know how much we appreciate you because of that, but I just want to reiterate for the whole community that we appreciate so much the amount of time that you spend just becoming familiar with PWS, becoming an expert with PWS, caring for our families, having empathy, and really just making the future of PWS a priority for you. We appreciate that so much.
Oh, well, thank you so much. It's really a pleasure to work with this community, and I'm always happy to make myself available. So don't hesitate if there are lingering questions to send me an email.
Great. Thank you.